direct oral anticoagulants, such as apixaban, rivaroxaban, dabigatran, edoxaban, these have been introduced into clinical practice since 2010. Over 3-4 years, all 4 drugs have been approved by FDA. At the beginning, of course, because of their cost and because people were not used to these medications, they were not used very commonly. But over the past 10 years, they have almost replaced Coumadin prescriptions, and most atrial fibrillation patients nowadays are using these direct oral anticoagulants. And we are seeing a lot of failures of these medications in terms of preventing an ischemic stroke, which means someone with atrial fibrillation who is using a direct oral anticoagulant who comes in with an ischemic stroke. I'm leading a multi-center observational study with participation from 20 academic stroke centers in the United States. And based on data that we are collecting, extrapolating from these data to the whole United States population, there appears to be about 70,000 oral anticoagulant failures in patients with atrial fibrillation just per year, just in the United States. So it's a big problem. So I'm glad that you asked this question in that sense. In these patients, unfortunately, we do not have very efficient approaches to prevent another ischemic stroke right now, as things stand. A multi-center study showed us that if somebody failed oral anticoagulants once, their risk of having another ischemic stroke, regardless of what you do, you might switch the oral anticoagulant to a different brand, you might switch warfarin to a DOAC, or DOAC to warfarin. But regardless of whatever you do, despite keeping these people on oral anticoagulants, the annual risk of having another ischemic stroke is about 9% per year, which is about 10 times higher than compared to direct oral anticoagulant phase 3 trials. What to do in these patients? Certainly a good diagnostic workup is important. If you find, for instance, a proximal large vessel disease like carotid atherosclerosis and such, you may need to intervene on it, like do surgery and fix that carotid artery. If you find, it's very rare, but if you find antiphospholipid syndrome, that might mean resistance to most direct oral anticoagulants, then you need warfarin, you need Coumadin, and you need Coumadin at a higher dose with a higher INR target. So you may need to adjust that. But unfortunately, and if you find a malignancy, such as cancer and cancer-associated hypercoagulable state, then of course you would try to treat the underlying malignancy. The problem is that these secondary causes are relatively rare. Many of these patients have real oral anticoagulant failures in the absence of a different cause. In these patients, it is a good idea to plan a randomized controlled trial to see whether combining left atrial appendage closure and continued oral anticoagulant would be superior to just switching the oral anticoagulant to a different one. This is something that we are currently discussing. But otherwise, you can use left atrial appendage closure compassionately in this patient population. But otherwise, we do not have a very good answer to this very important question. And as stroke neurologists, we are seeing a lot of these direct oral anticoagulant failures nowadays.